I am Dr. Hamza Islam from Pakistan, graduated from Punjab Medical College and certified in PPCR course from the research course from National Institute of Health, USA. So my topic of presentation is deep brain stimulation in the treatment of Parkinson's disease. So the abstract of the study is the Parkinson's disease is a common progressive neurodegenerative movement disorder. Parkinson's disease does not have a cure yet. Anti-Parkinson drugs such as levodopa lose their efficacy over time and are needed in higher doses as the disease progresses. An alternative to pharmacological therapy is deep brain stimulation, which involves transcranial placement of unilateral or bilateral leads wires, most commonly in the subthalamic nucleus or the globus pallidus interna of the brain, by stereotactic surgery. A careful selection of patients is required. So basically, we conducted a literature review from the previous studies of about last 10 to 15 years from the PubMed search, and we conducted this review to see the deep brain stimulation is effective in the treatment of Parkinson's disease or not. So let's go to the introduction and background slide. Yes, Parkinson's disease is a common progressive neurodegenerative movement disorder that affects nearly 1 to 3% of the global population over 60 years of age. The symptoms include resting tremors, bradykinesia, rigidity, postural instability, and a wide range of other motor and non-motor features that are common. So neurological deterioration is the cornerstone clinical feature. It largely manifests from loss of the dopaminergic neurons of the substantia nigra pars compacta, which project axons to the striatum. So simultaneously, neurodegenerative medications have also been extensively investigated, including adenosine A2A antagonists, estradiol and glutamate antagonist, amantadine and monoamine oxidase B inhibitors, salicylic. So these therapies are mainly symptomatic and do not change the disease course or treat the non-dopaminergic dependent features of Parkinson's disease that includes cognitive impairment, freezing of gait, and other non-motor features of the disorder, which often have a substantial influence on the quality of life. So for medical refractory cases, deep brain stimulation of the therapy of this thalamic ventral intermediate nucleus, it was approved by FDA in 1997 and is effective in treating essential tremors associated with Parkinson's disease. So later in 2002, FDA approved deep brain stimulation which targeted globus pallidus interna and subthalamic nucleus to treat levodopa-induced motor complications and advanced PD symptoms. And DBS made chronic and high-frequency stimulation of brain area which have the equivalent effect of surgery. Additionally, it considerably reduces the cost of usage of levodopa as the patients are non-compliant with the high doses or using levodopa for many years. So we have seen that this is reducing the cost of usage of dopa as a daily dose regime after subthalamic nucleus deep brain stimulation in up to 60% of the patients and GBI DBS in up to 50%. So thereby ameliorating overall quality of life in patients with PD. So in certain parts of the world, because of its effectiveness, better outcomes, more flexibility, and possible reversibility, less morbidity, and lower mortality, DBS is a promising treatment modality for the treatment of advanced Parkinson's disease. What is the mechanism of DBS? So for studying the mechanism, we go through the direct pathway and the indirect pathway that happens in the basal ganglia. So we see that the direct pathway is the sensory motor which releases glutamate that stimulates the striatum and releasing GABA and inhibits the GP internus that is going to disinhibit it by releasing GABA that is disinhibiting the thalamus. So this is the direct pathway for and the indirect pathway. Yes, this is the indirect pathway where we see that the sensory cortex is releasing glutamate that stimulates striatum, and striatum releases GABA that inhibits GP externus, and GABA is further disinhibiting the subthalamus, and glutamate is released that stimulates the GP internus, and then GABA is inhibiting the thalamus. So this is the indirect pathway where the thalamus is disinhibited. The mechanism of using DBS is that low frequencies are those in which electrode that are placed in the head are frequency below greater than 100 Hz. That performed by Nefina performed an experiment on Parkinson disease patients, found that high frequency stimulation, which includes frequency of around 200, stimulated the GABA aminobutyric acid GABA afferents on the two locations, GPI and SNR, resulting in inhibition of GPI and SNR. So ultimately, this inhibition of the thalamus reduces the motor symptoms of Parkinson's. This was so similar study was conducted, and the similar results were found on monkeys by the study that Zhou et al. And Broad et al. So another studies, Benzo et al. Studied the effect of low frequency stimulation on the subthalamic nucleus of anesthetized rats and observed decreased neurofiring, causing disinhibition of thalamic motor and increased cortical motor firing. But on the other hand, some studies have shown the stimulatory effect of high frequency stimulation. The previous study we have studied have shown that disinhibitory effect, but there are stimulatory effects also shown by this study, like Hashimoto et al. Experimented on 2 monkeys and studied the effect of DBS. We conclude DBS of subthalamic nucleus increased the neuronal activity of GPI. A study on rats by another scientist, Windels et al., and a study on PD patients by Galati et al. Showed that DBS of STN increased GABA in subthalamic nucleus and glutamate in globus pallidus, resulting in increased neuronal activity in corresponding zones. Another study, Harshi et al. Observed the PET scans, so that DBS of STN increased blood flow of STN, GP and thalamus, and decreased blood flow to cortex. Another study that is done by Gelly et al. Showed that HFS increased dopamine release in caudate and putamen. So therefore, it is difficult to pinpoint the exact way in which DBS operates, given the multiple hypotheses with sometimes conflicting mechanisms. The clinical features of Parkinson's disease, it has motor features and non-motor features. Motor features includes cardinal features, bradycardia, resting tremors, cogwheel rigidity, postural instability, freezing of gait, fixed posture, and the non-motor features include hyposmia, pain, sleep disturbance, sleep behavior orientation, time somnolence, mood disturbance that may include depression, cognitive impairment, and loss of executive functioning of the brain, GIT dysfunction that includes dysphagia and constipation, and genitogenitory dysfunction, overactive bladder, and sweating dysfunction like maybe low sweating or high sweating. So diagnosis of So that SPECT scan, MRI, tissue biopsies, CSF analysis, these are mostly done. Dopamine transporter single photon emission computed tomography, that SPECT identifies presynaptic dopamine neuronal failure in Parkinson's disease. MRI to diagnose PD is not recommended because MRI results might help differentiate PD from other types of the Parkinson's disease. Improved methods may have diagnostic and predictive implications in the future. So probable vascular contribution might be indicated by MRI findings of substantial cerebrovascular disease or basal ganglia. So outside the USA, iodine 123 meta iodobenzyl guanidine myocardial scintigraphy is commonly used to detect sympathetic nerve dysfunction, typically in PD patients. CSF analysis and skin and other tissue biopsies to check for synuclein disorders can help us detect PD sooner even in the prodromal stage. But CSF analysis and tissue biopsies have not done, or there may be in future we can detect Parkinson's disease earlier. So the conventional therapy that was used in the past was initial treatment was given by levodopa preparations, dopamine agonists, and monoamine oxidase B inhibitors. Levodopa-carbidopa enteral suspensions is also used to treat motor fluctuations and dyskinesias. Anticholinergic drugs can benefit young persons with tremors, but they must be taken with extreme care due to increased risk of adverse effects, especially those among impacting cognition. The patients that are mostly Parkinson disease come patients mostly in 60s and 70s of their age. So anticholinergics we do not generally prescribe because there is a risk of side effects from these drugs. So in individuals with significant symptomatic interval and extended onset with consecutive dosage, inhaled levodopa can be utilized to produce a quicker drug response. Now we have to see, after using conventional medical therapy and going to the deep stimulation, in which the patients that are to be excluded and patients included for deep brain stimulation. So we have studied different studies from that are done, and there is a criteria that these are the patients to be excluded. It includes severe psychotic patients and patients with that have persistent depressive disorder and that are non-responsive to levodopa and atypical Parkinson patients with dementia. So the patients to be included for DBS. So that include absence of dementia. That the patient that do not have any active psychiatric illness, and they are levodopa motor complications despite optimal management. And levodopa responsive patients can be used for DBS in future, and diagnosis of idiopathic disease patient where we use DBS. So to select the patients for DBS, pre-procedure evaluations of mood and cognition are recommended. So generally, we see for going for surgery or for using electrode to the brain, we recommend to go for psychiatric evaluation of the patient, or where the psychiatrist memory tests. The procedures that most commonly done include substantive procedural memory test. Is given a single puzzle to assess its mental capability, or the example that is to draw or to remember short version vision of the tower. So test is to evaluation memory and or visual memory testing. So and memory learning ability testing, working memory testing, and executive function tests are also done, which include auditory cognition function tests and linguistic rhythm tests. So different examples are given, and we see that we generally test a patient is pre-procedural to is okay for DBS or not. If he is okay for his mental discipline is okay, and his visual, verbal, cognitive function, executive function. So generally, tests enable us to go to other DBS treatment. So cost effectiveness and comparison is also compared with the standard treatment protocols. Like we have seen that for Parkinson disease, generally uh, medical treatment is done. That we have seen conventional medical treatment, but that cost we have the studies are different studies are conducted on this topic that deep brain stimulation is more cost effective than other modes of treatment. In a study conducted in USA by the neurophysicians, DBS was compared with pharmacotherapy for Parkinson's disease in patients with an average age of 60, and the incremental cost effectiveness ratio was taken out based on dollars per life year. It was found that the treatment for DBS resulted in a total discounted cost of around $90,000, discount for pharmacotherapy, which was around $91,000 over periods of 10 years. So another study conducted in the United Kingdom discovered that deep brain stimulation treatment resulted in a mean cost per patient of around £27,000 compared to the basic medical therapy, which includes about £73,000 per patient with basic medical therapy versus £46,000 DBS. So additionally, a mean of 1.35 quality adjusted life years, that includes 6.69 quality adjusted life years with basic medical therapy versus 5.35 quality adjusted life years with deep brain stimulation, yielded an increased cost effectiveness ratio with DBS treatment, with a 99% probability of DBS being co-active in Parkinson's. A similar study done in Sweden, Swedish study showed a net saving of Swedish krona that around 87,000 per quality adjusted life years gained over 15 years. So DBS cost effectiveness is associated with an improvement in the quality of life of Parkinson's disease patient around 18% when compared to those patients who were receiving medical treatment on the basis of incremental cost effectiveness ratio. So we have seen is cost effectiveness. Now risk and limitations. Hypertension is a significant risk factor for intracranial hemorrhage in Parkinson's disease patients undergoing DBS. In a study conducted by Zhou et al., the incidence of hemorrhage in hypertensive patients was found to be more than twice than of their normotensive counterparts. Microelectrode trajectories used in DBS also seem to increase the risk of intracranial hemorrhage. So hypertension, brain, these are the risk factors with these are the limitations for using DBS. In a study conducted by Shopach et al., the neurostimulation group and the patients in the medical therapy group were compared, and study concluded that depression was more frequent in the neurostimulation group. The study also noted that significant adverse effects related to surgery include cerebral abscess and non-specific edema. So, hypertension, hemorrhage, scatic depression, and brain abscess, non-specific edema, these are the limitations for using DBS. Also increases the likelihood of risks such as suicide and other hospital readmissions with mobility or infection. Progressive weight loss due to increased energy loss is seen in Parkinson disease patients undergoing DBS because they have to go for treatment and all this surgery. So energy loss and weight loss is seen. But post DBS of subthalamic nucleus, weight gain has also been reported. So this increase in weight may be associated with decreased energy loss due to reduction in the tremors. So a study conducted by Tripoli et al. Came to the conclusion that both medical and surgical issues significantly contribute to speech decline in subthalamic nucleus debris and stimulation patients, which can limit its beneficial effects. The reason for dysarthria, dysphagia, can be attributed to the stimulation of subthalamic nucleus and its vicinity to the corticobulbar pathways. So the connection of the subthalamic nucleus to the frontal cortex and basal ganglia structures forms a circuit that provides the basis for the mood changes, including anger post-DBS. So post-DBS, patients have suicide, may have increased risk of depression, post anger, dysarthria, dysphagia, weight loss, and we have similarly hypertension, brain abscess, the list for using DBS. So conclusion is DBS is used in the treatment of many diseases, including Parkinson's, despite being available for more than 25 years. Its exact mechanism is yet to be established. Despite its many shortcomings, DBS has shown to be effective in patients where conventional medical therapy has failed. Although being cost-effective treatment measures for Parkinson's patients, it is not about patients. Establishing the exact mechanism of DBS as well as objectively quantifying the impact of DBS on Parkinson patient is the need of all. So, thank you.